Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
I'm Dr. Christine Hart Kress, a board-certified women's health nurse practitioner and menopause certified practitioner, and I see patients via telemedicine in several states as well.
I am Dr. Aoife O'Sullivan, a board-certified family physician and Menopause Society certified practitioner, and I see patients through my telemedicine practice here in Oregon and Washington.
I am Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a Menopause Society certified practitioner. I have a private telemedicine practice, and I see patients in several different states.
Welcome back to the Dusty Muffins. Today we're joined by two brilliant OBGYNs, Dr. Ashley Fuller and Dr. Meredith McClure. Not only are they seasoned clinicians, but they're also the hosts of their own podcast with a name you will definitely not forget. We'll let them explain it themselves. We're excited to dive into their perspective on women's health, the quirks of being OBGYNs, and what it's like to share the mic as colleagues and as friends. Welcome, Dr. McClure and Dr. Fuller. Thanks for joining us.
Thanks for having us. What a lovely introduction, Aoife.
Yes, we're so excited to be here.
We're excited to have you. We all met at one of the conferences, right?
Yes, and then I met some of y'all on Zooms.
Yes.
When we were trying to get smarter and learn more about this stuff.
Yep. Oh, we were all in 8.
Yeah, that's right. Back in the beginning, I think, right? In the very beginning.
Yeah. Mm-hmm. I'm always looking for what Dr. McClure has to say on those case studies. I'm like, it's like having my own OBGYN in my pocket. What does she say?
It's so true. When we are all on that Heather Hirsch group, providers group, and you always give such great insight into everything.
Especially if there's a vulva. Thank you for saying that.
Yes.
But, I mean, if it's a vulva, I'm like, I gotta chime in.
Yeah, I gotta dive right in, right?
I know. I think
they deserve more respect.
I feel like our podcasts are like kindred spirits, right? Like, so we definitely want you to tell our audience about your podcast, how it got named, because we get asked all the time. And I really feel like our two podcasts are the ones that people go, oh, I remember that name. So we'll hand it off to you. Tell us about your podcast, whoever wants to go first.
Well, we are both vulvar specialists and do tons of work with patients who have vulvar issues. And unfortunately, even as OBGYNs, we felt like this is not something that we were really taught very much in residency, and not something that is really focused on. I mean, even just vulvar exams, and let alone whether people with vulvas even look at their own vulvas or know their parts, the names of their parts. And so I thought, we need to talk about this more. People need to be better educated about this, both patients and clinicians. And so we actually played around with a lot of different names for our podcast. So we actually used a little AI help. And we had some interesting options, like some Pleasure Palace.
Labia Library.
Yeah, tell us some of the good options that you had.
What were the other ones, Meredith?
This was all done, honestly, in the back row of the Swish Fall course. Ashley and I were sitting in the back row trying to contain our laughter when the AI would create various titles for our podcast. So yeah, Pleasure Palace was probably one of my favorites.
I love that.
But we came up with Labia Logic, and we thought it made good sense because it's focusing on the vulva, but it's also kind of like thinking about, just like education and kind of have that educational feeling to it, we thought.
Yeah. And then we didn't really know if that was the right name. And then even that night we threw it to Rachel Rubin. We were like, what do you think of Labia Logic? And her words were, I don't hate it.
So that was
we stuck with it. Yeah.
It's great. Yeah. And like Christine has done women's health for forever. Rebbecca and I are primary care docs, family medicine, and I can speak for at least myself and say I never was trained on anything about the vulva, really. You know, I knew from a picture book or from being tutored in exams that, you know, there was the clitoris, the urethral opening, the vaginal opening, labia majora, labia minora, and that was it. And really, after that and some vaginal dryness as you age, that was all I knew as a physician.
Yeah. I would agree too. And I really have, and I've said before, I felt like I had a really good residency with a lot of women's health. And I did go to I went to courses and learned how to do colposcopy. And I never learned what I learned at ISWISH. I just never did. I mean, and I don't even know if I had to put a catheter in, if I would could tell you exactly where the parts lined up before I hit the urethra. Right. I mean, so it just,
that's because we don't make the doctors do that. You just call a nurse. Can you go hit that?
Yeah. But we have to do it at some point. But you're right. The nurse is always like, how long before the nurse says, yeah, that's the clitoris you're trying to put the catheter in.
It gets a little murky up in there.
It can. Yeah.
It can. Yeah, for sure.
But I mean, even in OBGYN residency, Meredith and I trained together. She was my 4th year when I was an intern.
That's how you guys knew each other. I was going to ask.
That's awesome.
But we went to a very OB heavy residency. We trained at Parkland in Dallas. We delivered a lot of babies, did a lot of GYN surgery. And, you know, we had a little clinic that was kind of our vulvar clinic, but it was mostly about pre-cancer, like vein, we called it, clinic. And we just really didn't focus on just your regular routine women exam, looking at the vulva, talking to patients about vulva awareness, things like that. And I just think it's so important because I think, you know, patients don't have the right language to talk about these parts. It matters in the exam room. It matters in the bedroom too, and how they talk to their partners about what they like, what they don't. And so we just wanted to be able to have more conversations and kind of destigmatize the vulva.
Yeah. It matters because I think we're more like vaginas.
Right? Yeah. Even in, peds, being family medicine, you know, we see pediatric patients, or at least at one point we did. And I still see pediatric patients in my insurance-based model. And those well child visits, we talk not only with the child, but with their parents about what to call the appropriate body parts for several reasons. And so, you know, because oftentimes not only is it just all named the vagina, or it's named, you know, a cookie or a diamond or a, you know, whatever it is, it's not the appropriate anatomical name. And these children will grow up then as young women and adult women who never know what their body parts are called.
And so many people just call these, it's just a vagina. The whole thing is a vagina. And I think even clinically, we focus primarily on the vagina. I don't know what leads us to do that. If it's just more we worry about vaginal bleeding or, you know, STIs, which are going to be kind of higher up right around the cervix and things like that. But nobody really pays attention to the vulva, much as less do they even call it a vulva. They'll call the whole thing a vagina. And it's misleading. I don't know if it's is vulva a bad word and people don't want to say it. Like people go to their doctor and they have problems on their vulva and they say, it's my vagina. And clinicians won't even look at the vulva. And so Ashley and I both will be like, whoa. Is this an inside or is this outside? Because there's a big difference. It's different types of skin, different things happen in these different parts. So we need to definitely use the correct terminology.
What kind of things, just as OBGYNs or primary care, could we see presenting on the vulva that women might come in with, just for our listeners?
I would say symptom-wise, thinking of itch, pain, bleeding, bumps. Those are probably the basic things that we see. And there's many different things that can cause all of those to happen.
Yeah.
And I think now that pap smears they don't recommend them after 65, but I don't totally agree with. I think a lot of women over 65 are never having anyone look ever. Because if there's no concern, they if they're their primary care doctor and they don't say I feel itchy or things just like I feel really dry, like no one may look. And on top of that, just like a lot of patients will say they have itchiness and get just prescribed fluconazole, like thinking they have a yeast infection, and it may take a really long time for someone to actually look down there. And this is why patients with lichen sclerosis, which is a vulvar skin condition that's autoimmune, sometimes it takes them 5 or 10 years to actually get diagnosed with that condition. And I think some of that is because we're just not looking enough.
And part of why we don't ask as doctors is because we don't want to know, right? We don't want to know because we don't know what to do with it.
Yes.
So if a patient says, I'm having itch around the vulva, we're thinking, well, I hope there's obvious yeast infection down here, because if there isn't, I don't know what to do about it.
Yeah.
And so you're less likely to examine, you're more likely to just presume. And it's dangerous, really, isn't it? That lack of education.
Yeah. And there's so many people that get with, present with symptoms, and then they go and they get told it's a yeast infection, or we see them even get told they have herpes and things like that, when it's not anything like that. And those are diagnoses. I mean, obviously that's not the correct diagnosis, but it leaves a mark. And so many of these patients that we see have seen so many clinicians before they land to us, and they have a lot of trauma, and they don't trust and think that we're going to necessarily know, because they just set themselves up for, nobody knows what's wrong with me. And it's hard.
In your practices, what is the number one condition that clinicians are missing that patients finally land up in your care?
Lichen sclerosis is a big one.
Yeah, lichen sclerosis is a big one. It's not uncommon for me to see someone who has vulvar itching, especially in my postmenopausal patients, and they've been told that they have negative yeast. That their swabs are all negative, but people are swabbing in their vagina, and they actually have yeast on the vulva. And so, I think we all think like a yeast infection is like this cottage cheese discharge and itching inside, but like we can get yeast on the skin, and it may not have any of those things. It just feels like itching. And so sometimes it's not uncommon that I'll find someone that's been told me, I've had this itching for years, and every yeast thing is negative, every yeast test, but I do a wet mount from like a swab from the vulva, and I'll find yeast.
Yep. Or perineum, right? Or perineal.
Lichen sclerosis.
Yeah.
Yeah, it's probably because doing this, looking under the microscope is 5 more minutes of their visit, 5 more minutes of time that they don't have, right? And, I think, there's something to be said about looking at your own microscopy versus sending it off.
Yes. Well, a lot of times people aren't trained on microscopy. And then these days, a lot of the labs, if you work for a healthcare system, they have these rules that you can't have a microscope in the office. Yep. And so even less people are getting trained at it. And if it's not something you do on a regular basis, it's kind of hard to keep up the skill like anything. So it's kind of disappointing that so many offices are moving the microscope out and putting it in the central lab.
I hope they're still teaching residents that, because that's exactly what happened to me. Learned it all in residency to look in the lab. But we did not, when I went out in practice, no microscope, no colposcopy, gone.
Yeah. I did one of my early rotations in NP school in a underserved health clinic, and my preceptor made me do swabs on every single patient so that I would learn. Mm-hmm. There's nothing to be, you need volume to learn. So that's a great thing about being a student. You can spend the time to go look at, and work on focusing your microscope skills, right?
Actually, were you saying the labs have control over whether or not a clinic can have a microscope in it?
My understanding is, a lot of them are pulled into the central lab. So it depends on what the healthcare system wants to do. You have to be kind of CLIA certified to have a microscope and those kind of things. And so I don't know exactly, like they tried to take it away from me when I was at my healthcare system, when I said, no, I was a microbiology major, like you are just not taking this from me. And so, but I know other places like just haven't had a choice.
It's the competency training, because you have to do the same competency training that the lab techs do. And so it's about getting that system in place. So you have to look at like 10 slides and answer them with a 90 or some nonsense like that. And So I think a lot of the systems are like, that's too difficult to track that competency training, and they get caught up on their inspections. At least that's what happened in the military. And so they started taking them out.
Some of those like point of care testing things where like, I mean, when Ashley and I were residents and we were doing surgery, we do pregnancy tests on people when they have surgery, and they would have pregnancy tests with the sticker of the patient on them, and they were all lined up on the counter, and you'd walk over and go, oh yeah, mine's not pregnant. Okay, moving on. But there's all the whole logistics of, it needs to go down to the lab now, and it needs to get logged in this way. And so I think the microscopy kind of falls under that as well.
Struggling with mood swings, low energy, weight changes, or feeling dismissed about your hormones? You're not crazy. You're in midlife. I'm Dr. Rebbecca Hertel, board-certified osteopathic physician and certified menopause practitioner. And at Osteopathic Midlife Health, I offer personalized concierge telemedicine for women in multiple states, helping you navigate perimenopause and menopause with expert care focused on hormones, weight, sleep, libido, and more. My approach blends evidence-based medicine with a deep understanding of longevity and precision midlife health, because this phase isn't just about getting by, it's about thriving for decades to come. So visit www.osteopathicmidlifehealth.com and let's build your roadmap to lasting vitality.
So with lichen sclerosis, what do you see as the top presenting symptoms? How do you all approach lichen sclerosis? Well, let's start there. I have a following question, but we'll start with those.
I mean, I think the most common thing I see is itch. That's one of the most common concerns is itch. Sometimes there's burning. Sometimes they've looked, which I love when people look at their vulva and they notice things look different. So they might notice some white spots, or they may notice that things have just changed, because with lichen sclerosis, you can get architectural changes on the labia. So the labia minora, the smaller lips may get smaller or resorb. They may even go completely away with this condition. You may have a feeling of the clitoris changing because the clitoral hood can get phimosed or kind of adhesed over on top of the clitoris. You can get narrowing of the opening of the vagina. So sometimes they don't have itching symptoms, but they're noticing that they're tearing every time they have sex. Things like that.
Agree. And then there's kind of there's other things that I'll hear sometimes that'll make me go, oh, I need to look at your vulva, which would be if a young person, a reproductive age person tells me they have vaginal dryness, I say, I need to look at your vulva, because they might misinterpret that as a vulvar thing. And again, they might be telling me it's their vagina, but really it is their vulva where they're feeling dry or irritated. Some will present with constipation, anal fissures, things like that, because lichen sclerosis can be around the anus. The pelvic floor dysfunction. So many patients get diagnosed with this by pelvic floor therapists because they're going to them for pain with sex or constipation. Even urinary symptoms in some older patients get dismissed, I feel, because some of our vulvar skin things will cause changing of that anatomy, that their urine stream is different, or they think they have a UTI, they're kind of trapping urine, things like that. So those are things when I hear from patients, I don't just dismiss it as a urine thing and run a urinalysis or whatever. I'll be like, I need to look at your vulva.
Any more lichen sclerosis questions there, Christine? Do you look like you?
I do.
Treatment.
Go
on then.
Treatment.
Yes.
What's your favorite treatment?
Gold standard is a super potent topical steroid. I recommend ointment, not cream. Ointment will stick to the labia and vulva better and absorb better. I think the biggest thing about this is that it is not a treat for 2 weeks and then stop. So many people are scared of steroids in the vulva. This is absolutely the treatment for it. When you use it, I usually use it if I have a new patient that has a fair amount of disease. I will actually have them use it every day for like a month or two until we get things into remission. And then the big thing is they have to keep using it. And I usually decrease how often they have to use it to a maintenance dose of like twice a week. I also love putting a little estrogen cream with it, because estrogen cream plumps up those tissues and is a nice balance for it. But a lot of patients will say, I'm really concerned about using a steroid on my vulva. The skin already looks so thin. I don't think I should use this. And you really have to explain to them that like the top skin looks really thin, but there's like this scarring that's going on underneath the skin. And that's why we need a super potent steroid to get to that. And this is what actually prevents cancer. Because when you have lichen sclerosis, it does increase the risk of cancer slightly. And so this is what actually prevents that.
No, you go ahead.
Oh, okay. So showing people how to use their steroid, because a lot of people just give it a prescription and say, put it on down here. But Ashley and I we have a hand mirror that costs like $8 on Amazon, and we show the patient what we're seeing and how to put on the steroid. where to put it. Really, they just need a tiny, tiny, tiny amount. And I maybe tell my patients, like, I'm giving you a tube that's this big. And if you call me in 2 weeks and say it's gone, I know it, you've used too much, because you can use too much. And if you use too much, that's when you can have problems with potentially burning that ointment gets onto skin that is not meant to have that much ultra potent steroid on it, like the inner thigh and things like that, and they'll have problems. So I think that's important to tell them. Also telling them, like Ashley said, that regular use of the steroid is what prevents cancer. It also prevents progression of the scarring, which is the resorption of the labia and things like that. So I'll say, we have labia here. We're going to keep those here. I can't reverse what's happened with steroids, but I want you to keep this architecture that you still have, and using your steroids regularly will help with that.
And we think lichen sclerosis is an autoimmune condition, don't we? We're not really sure of all the things that cause it, but it seems to be us reacting to our own poor vulva. Yeah. You see it in other kind of in conjunction sometimes with other autoimmune conditions, like a thyroid disorder. Vitiligo is another, and a lot of times it's in a hormonal shift time of life. So things to be looking for if you're postpartum. There are definitely people that have had it since birth. It kind of goes away potentially in puberty and resurfaces at another hormonal fluctuation time. So perimenopause and menopause is another time to definitely look. So when I hear people, say I have itching in my vulva, I'll be like, what are your periods doing? Because I need to know what's going on there too, because that will give us some cues as well. Yeah, because we know how anti-inflammatory estrogen is. And so when we lose it, we start to develop a lot of these autoimmune inflammatory conditions. Ashley, when you sometimes tell your patients to use the vaginal estrogen with the steroid cream, do you have a method? Do you use the steroid cream first and allow it to penetrate and then apply the estrogen cream, or it doesn't matter?
I usually have them do it alternating nights, because I always think when I give patients homework, like, would I be able to do this? And I think using something 2 nights a week is like really hard, unless it's the nights I change my patch, like the day I change, something like that. Yeah. So I tell them, like, they could get on a system where they do alternate every other night. They just change the tube so that it's an easy thing. They know they have to put something on every night. So maybe they do Monday through Friday, they get the weekends off, and they do like 2-3 nights a week estrogen cream and 2 nights a week clobetasol or whatever steroid they're using. I think it's easier to do it on alternating nights.
That's really helpful. Yeah. And of course, a key point that you made is we really have to continue this forever. So not to stop your treatment, or it just comes back.
Yes.
Yes. Tell us a little bit about Clitember. What's that about?
We've dedicated the month of September to the clitoris.
Fantastic.
So just another part of our vulva that we don't talk about enough and that we don't know enough about. And it's actually really shocking that they are still like learning things about the clitoris, because no one's ever really studied it. A lot of the data they used about how many nerve endings were in the clitoris were from cow data, like not even human clitoris.
Really?
Yes. And they just mapped
cow has clitoris too, I guess, huh? Does everybody have them?
Apparently.
I remember that.
I wonder if whales have them. Wow, anyway, go ahead. So
we just don't talk about it enough. We don't, I think that clinicians especially, I never was taught to look at barely look at the vulva, but definitely not to look at the clitoris. And so, on every exam I do, I retract the clitoral hood, I look at the clitoris. I tell the patient I'm doing this because it's something they probably never have had done before, but it's important. And, I think so we wanted to kind of raise more awareness about the clitoris, what we know about the clitoris, what we don't know about it, and just what a unique organ it is, since its only function is for pleasure. There's no urethra in it, and it is incredibly sensitive and can be a incredibly great part of the body. So we just want to be able to talk about it more.
Yeah.
Who's got
also
a clitoris handy?
Happen.
Who's got a model handy? We love show and tell. Oh my God, she's big.
It's a big one.
There she is.
So go ahead, tell our audience, teach us, oh great wizards.
This is the clitoris. Of course, what you can see with your own eyes is just this tip right here, which is the gland or the head, which is homologous or the same body part as the head of the penis, because female and male genitals are actually homologs, or very similar. And the hood or prepuce or foreskin, if you're familiar with that term, is something that we have on the vulva as well. It's a branch of the labia minora that goes up and over the head of the clitoris, and you should be able to retract it all the way back to see the head of the clitoris. And then but underneath the skin, you have a body. This is the body that goes up and is suspended by a ligament from the pubic bone. Then this will then split into these legs or crura that are on top of bones of the pelvis. And then these are the bulbs that hang down and go on either side of the vaginal opening. And this is a lot of erectile tissue right here. So that is the entire clitoris.
That is one big demo. I've never seen a clitoris that big.
It's made by a company in Germany called Glitter Clit. So shout out. They have like full like stuffed models of male and female genitals. So my German friend found them and brought these to me from Germany.
I love that. I'm gonna hunt for a good clitoris and a good vulva.
They're good. They're really good.
She's beautiful. So the 10,000 nerve endings on the female clitoris, is that information from cows or that is actual human information?
That was Maria Yoloko's recent paper. Okay. Right, Ashley?
So that's accurate.
They actually started looking at clitorises from people transitioning, having gender affirming surgeries, and so they looked at the clitoris that way. And that's like one of the first times they actually mapped or looked at the amount of nerve endings on the clitoris for humans. So they had more like 10,000 nerve endings, not 8,000, which is what has previously been reported.
Amazing. Yeah. Even more than the male penis, right?
Yes, almost double more.
Yeah. And like you said, its only function is for pleasure. That's the only part of our body that is specific use is only for pleasure. It's great for our listeners to hear that. Yeah. Because it is ignored in real life. But not anymore, not after Clitember.
Yeah. Well, and people can have problems with their clitoris, and they can have pain and even persistent arousal from various things can happen. And the next episode we're interviewing Dr. Jill Krapf, who's an amazing gynecologist in Tampa. And Ashley and I both had our minds blown at certain moments of our discussion with her about clitoral pain and why it happens and how to fix it. It was awesome. So stay tuned for that one.
Yeah. Because some women have pain with orgasm, and then other women say that they can't orgasm. How do you approach both of those without giving away all Jill's secrets? How do you approach the I used to be able to have an orgasm and I can't anymore, or my orgasm is just blunted? How do you, Dr. Fuller? What's your approach on that?
So yeah, this is fascinating, and I think there's there's supposed to be a paper coming out by Irwin Goldstein. I'm surprised it's not out yet, but at some point in the next couple of months, I would imagine it will come out about like kind of a process of care about orgasmic dysfunction, which I think is amazing. And he presented it back at ISHWISH earlier this year. And basically orgasm is a pretty complex bodily function, and you have to have kind of two parts of it, the excitation and the inhibition. If you have too much excitation, then it's too sensitive and you don't it's almost painful. You don't want to keep touching the clitoris. If there's too much inhibition, you may try and nothing happens. So then you're frustrated. So you need this kind of excitation, inhibition until it kind of overcomes the inhibition. And when one of those parts isn't working right, then you have orgasmic dysfunction. So you have to kind of look at what is the dysfunction. Are you not able to achieve orgasm? You have too much inhibition? Are you having a muted orgasm, still too much inhibition? Are you having pain and that's like too much excitation? Those kinds of things. So he has some really interesting ideas of medications and things you can use. But one of the first things I always do is look at the vulva, because I want to look at their clitoris. Do they have lichen sclerosis that no one ever told them about? And they have phimosis and the clitoris is kind of buried. Or do they have, we can get these adhesions from the clitoris from the clitoral hood of the clitoris and get what we call keratin pearls underneath there, which are just hardened dead skin cells. And for some people that are really painful or sensitive, and that might be a reason they're having problems with orgasm. I also want to look at their estrogen status, which I often can tell from questions, but also by looking at their vulva.
Do you feel like, the average OBGYN office should be able to handle those adhesions? Do you find, like, in your colleague world that anybody is trained on them, or pretty much do they all need to go to vulvar specialists to have those adhesions taken down?
We definitely aren't trained in it, for sure. I mean, I don't know about you, Ashley, but when I did OB, we did the circumcisions. So the first clitoral adhesion procedure I did, after, of course, still being nervous about doing it, and going to the anatomy lab about 4 different times to dissect the clitoris out to understand the whole anatomy myself, it's very similar in the procedure. The first one I did, I kind of just went right into the zone and was just like doing an infant circumcision, except we don't cut anything in this particular procedure. We just push the foreskin back over the glands. But there's some technique to it. I think the numbing process and things like that and understanding that anatomy is very important.
Is there a self-check process for women? Like with a mirror, can women like you can with a guy?
You should be able to put a mirror down there and retract your clitoral hood and see if you to look at your clitoris. But, the data shows about 25% of women have clitoral adhesions. They may not be symptomatic from them. So when I'm examining someone's, doing any kind of exam, and I look at the vulva, if they're just there for their women exam and they don't have any concerns, I may say, oh, you have a few adhesions, or your clitoris is the hood doesn't retract completely. Do you have any symptoms of pain or problems with orgasm? If they say no, I'm just like, well, don't worry about this. But sometimes, sometimes people can be totally asymptomatic.
Yeah. And we'll see women with lichen sclerosis where the hood is completely covering the head of the clitoris and they still can have orgasm. Fine. Mm-hmm. And in those cases, we're not having pain. If you're not having trouble with orgasm, it's totally fine for it to be like that.
No, I want to go check. Never look.
Christine's going to be sending us some upside down pictures. We're trying to see.
Do you think it's right? Now I'm just curious. I was not taught that at all in any of my training. I never looked at a clitoris, ever. Now I wish I wasn't telemedicine, because now it's a little more challenging. Can't look at them still.
Yeah.
Well, it shows the lack of importance of women's bodies, really, in the history of medicine, right? I mean,
Absolutely.
even, we've talked about it before, but even medical schools and residencies and fellowships were all developed by men for men. Women have gotten in there, but they weren't designed for us. And the study of medicine as well, that none of us were taught about this in our training. It's really astonishing.
Yes.
How it's been ignored. Yeah. We find a lot with our patients, they'll complain of loss of sensation in the clitoris as well as they go through that menopause transition. So we often talk to them about using tools and toys in the bedroom. Do you talk to your patients about that, or do you find that they don't mind including those in the bedroom?
Every day. We highly recommend vibration. Yes. And some people is vibration with the suction products and things like that. But the nerve endings do change as we progress through our years and the hormonal status of things and other medical conditions. We have high blood pressure, diabetes. I mean, all these things can affect our nerve endings. And these are tiny, tiny nerve endings. And some of these conditions go for the tiny ones first. And they don't go for the big ones like your brain and your spinal cord right off the bat. Vibration is something that these nerve endings will never lose capability of having pleasure from. So we strongly support using tools to help patients to achieve pleasure.
Yeah. And a lot of times patients, as I always talk about libido a lot, as libido, people say they're having lower libido. I think for a lot of patients, one of those, there's a lot of factors, of course. But one of the factors is, well, it just takes me so long to get there, and so I think that using a vibrator, having toys that can get patients aroused more easily, can get that, get that arousal and pleasure there faster, can help with that kind of, idea that they may not want to do it because it just takes so long to get there.
Want the Dusty Muffins at your next event? We do panels, live podcasts, and talks that bring the heat, literally. Corporate, CME, or retreats, we've got you. So hit us up at thedustymuffins333@gmail.com or DM us on Instagram at thedustymuffins.
Yes. Do you, on that same kind of vein, do you compound at all creams, topical creams for your patients with, some of them have, that's the Scream Cream, we call it, which is a little mixture of topical application to help with sensation. And do you guys use any of that in practice?
I do occasionally, just when you're trying to help people kind of navigate through all of that. I mean, those products are typically involve, could have some hormone component. It can have nitric oxide agents that help kind of dilate the blood vessels, which of course estrogen also does that too, which is why I tell people vaginal estrogen is the greatest thing in the world, saves lives, saves relationships, and rubbing that on the clitoris is totally fine and helping getting blood flow to that tissue. There are sometimes those compounded products will have sildenafil, which is Viagra, in it as well, which is also involved in kind of relaxing the smooth muscles and getting more blood flow there. That hasn't totally been shown to help vulvas as much as it has penises. I believe there's some things in trial at the moment using that with testosterone, I believe, right, Ashley?
There's a topical sildenafil for arousal disorder that a company just finished a phase 2 trial with. So, and had overall good results. So, stay tuned on that. But it's a blood flow medication, right? So it's just getting more blood flow there. I think the thing with Scream Cream is kind of like, if you're going to rub anything on your clitoris, for 10 minutes, 30 minutes before you're going to have sex, pretty much anything's going to work, right? Any kind of, stimulation of the clitoris is going to kind of get blood flowing. So I don't know that you need all that. Although I do think it's an interesting idea to try to use some of these, like things like sildenafil or Viagra to try to kind of help with more blood flow there. But I think estrogen can do a lot of this too, kind of what Meredith is saying.
Yeah. And just looking at the patient as a whole, when it comes to orgasm is so important, from hormonal state of menopause, perimenopause, lactation, but also medicines they're taking, because there's so many medicines that affect people's sexual function. Yes. These ones that, we use for depression and anxiety. So many people have orgasm trouble with those medicines, and those can be actually really hard to treat. But it is definitely a thing. So looking at kind of the big picture.
Yeah, I find with my patients, I would say 50% of them realize that their antidepressant can have an effect on their on them sexually, and 50% have no idea that it can cause that. So we really do need to be better about teaching patients, if we start them on something like that, to give them a heads up to be aware of it, because there are things we can do. Sometimes we'll add a little bit of something else in, especially Wellbutrin, to help counteract that, especially if it's libido. But I think if you don't tell a patient and they're not looking out for it, they can go for years with coping with this and not have a clue it's caused by a medication and reversible.
So what about and this was an interesting diagnosis that Christine actually brought to my attention, because I don't think I've ever seen it. And if I have seen it, I didn't know what it was. It's desquamative inflammatory vaginitis. It's a mouthful. Why it's often missed and how it differs from yeast and BV.
So Ashley and I are kind of... we're getting ready to try to do an episode on this. We both are like, oh God, we're gonna have to read a lot more on this. I mean, we see it for sure. Yes. It's not something that's taught. And honestly, like, I got into the vulva because of vaginitis. That was my gateway. I was frustrated, and it was DIV. That's what got me into this. Is I had a patient who was I couldn't get her better. I could not fix her problem. And in my mind, I'm like, maybe we could try some estrogen. Like, it's kind of like thinking outside the box. And eventually that, some things kind of helped. And I went to my first vulva conference like 6 years ago. They do exist. And I realized I did my job wrong. And that was what led me down this path. And the DIV is one of those things. And it's a really inflammatory skin disorder. People, when they have this, it's this copious vaginal discharge. It can be really painful and irritating. It can cause clitoral adhesions. We talked about that with Jill in our episode. Their pH is normally very high. You look out under the microscope, you see tons of these little white blood cells that are kind of your body's inflammatory response. And a lot of them, they'll get swab after swab after swab in the offices. And maybe there's something on it that gets treated. They're still not getting better. Maybe there's nothing on it. And really, this is a skin thing. And I remember my patient that had this, I looked at her and I said, I feel like your vagina skin is falling out. And that's what is happening to you. And because that is what discharge really is. It's a transudate from the vagina. And this is one of these things that's just so inflammatory and it just pours out. I mean, it just looks like the walls of the vagina are just leaping and angry. So that is what it is. And it's treated typically with steroid, just like any skin disorder, sometimes an antibiotic more as an anti-inflammatory than it is trying to kill the bacteria, and then really trying to reestablish a normal pH with the hormone, with estrogen and things like that.
I always used to appreciate with DIV how the discharge is really very yellowish and very tacky in trying to differentiate that. I think it was a bunch of women coming in and there's no yeast, there's no BV. And I'm like, all right, what is the next thing? And just reading up and I'm like, but it's yellow and it's weird looking discharge, which is that skin. And back in the heyday, 30 years ago, we used to just use Annucell suppositories. And then I see more in the guidelines. I thought I saw, and it's been a couple of years since I've treated that, but I think it was like clindamycin was the other one that I see used a little bit more now than, because women are like, I got to put a hemorrhoid suppository in my vagina. I'm like, yep. And for a really long time, like 2 to 3 weeks of long treatment, correct? Am I remembering that correctly?
Yes. So I think the original was like 3 to 6 weeks. I mean, the thing is, DIV is really hard to treat. I mean, so I think there's some microbiome situation going on there also. And I think this is kind of where we, they can send off these tests now and get their whole microbiome, figured out, but still we don't know exactly what to do with all that. But, we use kind of like Meredith was saying, estrogen to help with the pH, and then we have clindamycin for the anti-inflammatory, and then also the steroid. And so oftentimes, if they've had it for a while, I'll just make a triple cream compounded with estrogen, hydrocortisone, and clindamycin. And then once you kind of get rid of a bunch of the inflammation, that like with the Clinda, then you kind of need to reestablish a good microbiome. So then sometimes, this is what Jill was telling us too, and when we were recording with her, is kind of taking the Clinda out and adding like a probiotic at that point to kind of reestablish a good microbiome at that point. But it's complex, and hardly ever do I just treat someone and then they get better and they're fine. It's usually like some kind of maintenance dose with some of these medications, which really makes us kind of wonder what's the underlying etiology. We know there's some aerobic bacteria, but that's not the whole story. And so, I think there's definitely a lot of room for more research in this area.
Yeah, some even think, in some cases that lichen planus, which is another autoimmune skin disorder of the vulva, but also in the vagina, because lichen planus can happen in mucous membranes like your mouth and in your vagina, that maybe those two are related. I do see sometimes where you kind of see these intertwined, but a lot of the people with DIV need to stay on a maintenance of some kind of a steroid once or twice a week in their vagina, kind of like an Annucell suppository, things like that.
Yeah, there's nothing like treating a lichen planus patient and you're like, can you open your mouth, please? And they're like, you're women's health. What are you doing looking in my mouth?
Lichen planus is tough.
Yeah.
It is. I know. But it's good when you as a clinician, when you open your aperture to some of these other zebras, it really makes you feel so much more empowered as a provider, because you're like, okay, finally, it's like when you learned how to treat perimenopause and you're like, aha, I feel like a superhero because now I can do it, because you don't learn these zebras, just like ureaplasm and mycoplasm. Like that's always my go-to after I try all my easy things. I'm like, screen for that. And always, one of them is always positive. But I didn't learn that in school. I learned it from working with a OBGYN who's older than me. That's like old school OBGYN world.
I think the ureaplasma mycoplasma is also a whole kind of Pandora's box of controversy too. Of like, are these confounders? Is this thing causing it? Because sometimes, I mean, I sometimes check them too, but then sometimes you treat them and they go away and their symptoms are still there, and you're like, well, that wasn't it. And sometimes it works, but it's I definitely think there's a lot of interesting research being done on microbiome, and I think that's part of it too. Like, could some of these mycoplasma and ureaplasma things just be part of a normal microbiome, or are they always pathogens? And I think there's people in different camps on that.
And this is why Ashley and I keep putting off the complex vaginitis episode. She keeps bringing it up, and I'm like, can we do more libido?
I want the complex.
We just recorded our basic vaginitis episode, and it got complicated too. I mean, even just recurrent BV and recurrent yeast and the hard to treat yeast, and what's shocking to me is that like vaginitis is one of the most common outpatient visits for women, and yet we got like a little bit of it in residency, and it sounds like it's like this really simple. You either have BV or you have yeast and you move on with your life, but it's not that simple. It's actually really complicated a lot of the times, and we didn't really get great training on it in residency. Yet it's like OB/GYNs see this every day, but like so often this person's back for the third time in 6 weeks with the same discharge, and you're kind of like, well, this what do I do? This is how Meredith kind of talked about how she got into this. So we didn't really get good training on this. And so you end up playing detective, and then you realize, oh, this is actually really fun trying to figure this out for people. I don't want them to have this, but like you have to piece together all these different parts of physiology and hormones and pelvic floor and the patient's history to try to figure it out. And you get to play detective, and when you figure it out, it's the most rewarding thing.
That's awesome.
I'd say you have some very grateful patients. Speaking of things that we were not taught about but are so important, vaginal estrogen and this menopause transition and the changes that occur. What did you think of the FDA meeting that's available on YouTube if anyone listening wants to watch it? It's 2 hours long. It was very interesting. There were some great doctors there. The goal was to speak to the FDA about removing the black box warning from vaginal estrogen because it's so safe, and that label scares women and doctors away from using it. Did you see it? Did you enjoy it?
Yeah, it's the greats of the greats that were sitting there. It was awesome.
It was great.
So
I know
it needs to happen. And we need to warn patients when we prescribe it, because the thing says you're going to get dementia and cancer and blood clots, and it's completely wrong. I mean, I had a patient this week email me saying that somebody was trying to get her to do a $3,500 laser treatment because she had breast cancer and she couldn't use vaginal estrogen. And it's so wrong. And, why are we trying to profit off of this? And, because this is so safe and fixes the root cause. And, she won't have to go back and get another $3,500 laser treatment every, so often for this.
Yeah, they're big on selling that.
Yeah, such a safe product, such a great product. There's no one I wouldn't give vaginal estrogen to. And I do let patients know, you're going to open up that box and you're going to see this warning. You can ignore that. It's, old data that doesn't even pertain to vaginally dosed estrogen. It's sad.
I know. And I think we all give our patients that heads up, right? And yet we all have patients who come back a few months later and go, yeah, I did pick it up, but I did look at the insert and I was too scared to start it. So it is a barrier to care. Sure. And it takes time as well. We shouldn't have to sit down and give a 5-minute lecture on the Women's Health Initiative study and this black box warning every time we want to prescribe the equivalent of over-the-counter 1% hydrocortisone cream. It's a waste of time, it's a waste of energy, and it doesn't benefit the patients or us. So it's time for it to go, but it's a very slow process.
Not to mention the roadblocks they get despite us telling them that this is safe and fine. It's their pharmacist telling them you can't do this. It's the orthopedic surgeon that told my patient to get off of her vaginal estrogen for her knee replacement, and then she landed in the hospital for a week with a UTI. Like, this is crazy that this still gets perpetuated, and it needs to stop. And we need to stand up, and I think this is hopefully a step in the right direction.
So for our listeners, as we lose our estrogen, as we go through that menopause transition, it needs to be replaced. because once we start to get symptoms like urinary tract infections or vaginal dryness, pain with intimacy, discomfort, little cuts and irritations on the vulva, those don't go away. They just continue to get worse unless we actually start to use the vaginal estrogen. So I know we think it should be sent to you in the post on your, 37th birthday to just put it in the cupboard until you need it.
I know. Well, hopefully more, primary care and OBGYNs will, add that to their screening questionnaire, and it would save so much time if they would just ask and give and teach how to use it, and off everybody goes whenever they need it, to include, when they're on birth control pills.
Yes.
Yeah, actually, and you mentioned Dr. Rachel Rubin earlier, but she and her team did that little study where they worked out if every woman who was Medicare aged was given vaginal estrogen, then we would save somewhere between $6 and $22 billion in Medicare every year. That's a lot of money.
It's a lot of money.
It's a ton of money.
Yeah.
So I have one final question for you all. And because I think you all are our first OBGYNs to be on our podcast. We've had lots of other specialties. Well, I guess.
No, we had Dr. White, Dr. Kate White.
You're the most recent in my mind. But we love them tons. I don't know why. Well, because there's two of you. So my question is, what do you have to say for the patient who's frustrated that their OBGYN cannot handle their menopause issues and they feel like that's their job? And what do you say for your clinicians who still are not handling women's menopause issues from the OBGYN perspective?
I think this is complex. I think that we didn't get a lot of training on menopause in residency. We trained right after the WHI. When I got it under practice, I had to ask my partners, how do I prescribe HRT? I didn't know how to. And so I think that, I think that's improving. I think there's more menopause education. I think just there's more awareness about menopause and perimenopause. I think being a general OBGYN is really, really hard. I think being a physician is hard, but I think being a general OBGYN is really hard. You're running back and forth to labor and delivery, delivering babies, doing GYN surgeries. And, at least for me in my practice, and I think you guys have similar practices, I have hour-long visits with patients because I think with perimenopause and menopause, it takes that long to unpack what's going on. What are the symptoms you're having? There's usually a lot of emotion that goes with this too. And then what are our goals? And let's talk about the science and the risks and benefits and all that kind of stuff. It's not a 15-minute visit. So, I see it from both sides. As patients, I think it's frustrating when your OBGYN is not able to help you with these things, but I also think as an generalist OBGYN, it's not that they don't want to help, it's that they're just, the time constraints and the pressures being put upon them by the system are so much that it's really hard for them to manage these things in a 10-15 minute visit. So I see it from both sides.
Dr. Fuller, Dr. McClure, thank you both so much for joining us today. We loved hearing the stories about your podcast, your take on women's health, and the fresh honesty you bring to the conversation. For our listeners, you can find their show Labia Logic wherever you get your podcasts. Don't forget to subscribe to the Dusty Muffins too. We'll keep serving up the hot flashes, laughs, and real talk.